before really diving in, I want to give you a bit of a framework for where I'm situating some of this work about social relationships and health. I don't know what's up with Mr. Clicker here. But... So we have a wealth of research now about the many ways that our social relationships can matter for our health, right? So all different dimensions about the qualities of our relationships, the structure of our relationships, different factors about timing that can relate to many different aspects of health. So we see effects for physical health, right? Whether it's mortality ultimately or acute and chronic conditions. There's many ways that aspects of relationships are relating to multiple aspects of physical health, and physical health is affecting our social relationships in turn. I think it's fair to say that a good bit of this research has focused on health behaviors. So the ways that our social relationships influence us to maybe engage in negative health behaviors like smoking or drinking, or provide some social control that might encourage some positive behaviors like healthy diet and exercise and limit some of those negative behaviors. But a lot of attention to how our health behaviors are affected by social networks. And of course, we have research on mental health as well. So a very tight coupling between our social relationships affecting our mental health. Social relationships that can cause stress or strain, that can be detrimental to our mental health, but relationships can also provide support in ways that might be buffering the negative effects of other stressors and limiting mental distress. So we have a decades of research now thinking about the many ways that social relationships are critical for our health in ways that might be interrelated between behaviors, physical health, and mental health. But I think it's fair to say that when we think about this across the life course, we see very different pockets in how we're thinking about networks in relation to health. So in adolescence, we are highly focused on teens' friendships, on peer influence to, say, use substances, or different ways we can measure peer selection and influence in peer networks. And this isn't an accident. Peers are highly developmentally salient and really important for adolescents' health and particularly mental health. But then in midlife, we're focused much more on the family. We're thinking about marriage, marital timing and sequencing, marital quality, parenting, and how relationships might be affecting kind of individuals within this family context in particular. Then in older adulthood, we might be paying more attention to social support, to the ways that older adults are receiving care or engaging in social support in ways that might be related to physical, mental health, and even mortality, or how older adults are engaging in social participation. So you're continuing to volunteer to make sure that you're not socially isolated in ways that can have effects for mental and physical health. And again, this isn't an accident. These are relationships that are salient within those life course stages. But this also means that we don't know very much about the structure of our relationships having effects over time in the life course and across these separate life course stages. So most of my research is thinking about adolescent network structure. So thinking about friendships in schools, school peer connections among adolescents. And so we often think about what might be flowing through a peer network. So peer influence to, say, smoke or drink. We might think about selection and kind of teasing apart selection and influence now with some of our more advanced kind of simulation models. But we could also think about networks as creating a position that might relate to health behaviors, or mental health, mostly in adolescence. So we could think about the tight-knittedness of friend groups or individuals that might span different groups and the ways that that network structure is creating a position that might have effects on adolescents' mental health. Of course, those peer groups are nested within a much larger structure itself. So we can map out this web of social relations using social network analysis within the school overall. So here's an example. You've got adolescents in, I think, 6th grade here. So the girls are circles, the boys are squares, the lines between them are who they nominated as their friend. So you can see we've got a lot of gender homophily. 6th graders still think that the other gender has cooties, right? So we can look at a lot of descriptive features about this network. But what I want you to kind of take away from this sociocentric network is thinking about how we see these differences in structure, which might create different positions for adolescents' mental health. So for example, it might not just be about the number of ties you have, but the ties of those ties. So are you connected to other people who are highly connected? Does that make you nested in the heart of the network, being compared to being more on the fringe of the network or relatively isolated or entirely isolated, lacking social ties to other in-school peers? And we could see a difference with something like a measure like Bonasich centrality of are you connected to other people who are highly connected versus are you connected to people who are relatively unconnected? Are you the queen of the nerds? If we go back to kind of our breakfast school or breakfast club kind of school groups here, right? So all of these different positions, and we truly can measure hundreds of different centrality positions now, can have different effects for health. And we've studied this fairly well in terms of adolescent mental health in particular. So what I want to focus on today is even simpler, coming from this overall web of relations, the sociocentric network data within schools. We can break it down to two fundamental building blocks that's creating this network structure. Out degree, how many ties you're sending, who you're nominating as a friend, what I'm going to call sociology, just for ease of conversation today. And we could distinguish this in our directed data from in degree, so your popularity, how many people are naming you as a friend in turn. And we know a lot of sociology happens around popularity, right? There's a lot about making aspirational nominations to more high status peers, for example. So it's not always mutual. If you're nominating somebody higher in the social hierarchy as your friend, you know, that's more likely to be an asymmetric nomination, for example. So popularity and sociality, while they're these two kind of separate building blocks, they're not just the same thing or entirely symmetric per se. But we can think about these as having kind of this conceptual importance to teens among their peers. So sociality is representing how you see yourself in the peer environment, how you see yourself connecting in this social environment that's really highly salient in adolescence. And popularity is how other people see you, right? So how your friends or your peers see you fitting into that social environment. So we've got kind of two different concepts being measured here through these different structural measures. And we find that both relate to mental health, right? Sociality tends to be beneficial for teens across the board, seeing yourself as belonging in the peer environment, especially when you're spending 8 hours a day in school, that tends to be a good thing for your mental health, right? But popularity is a bit more of a double-edged sword, particularly for girls. Right? So we see that having higher popularity can be associated with better mental health. And we might think this conveys kind of social status, perhaps self-esteem, or in general, we like to be on the top of the social hierarchy. Right? So it's a good thing for mental health, but it can become detrimental. So having high status, particularly in high school, might relate to having feelings of higher scrutiny about your behavior or pressure to maintain that status and to act in certain ways that have to maintain status among your peers. And we see that reflected in how popularity relates to benefits and detriments to adolescent mental health. So now we're thinking about this network structure, these two kind of building blocks of how adolescent network peer structure relates to mental health. And, you know, much like me in the throes of my dissertation, you're engaged with thinking about these different structural components. And what was keeping me up at night was, does any of this matter after adolescence? We have spent decades researching adolescent networks, but does any of it matter once you're an adult? And intuitively, we might think, sure, it's a developmental stage. What's happening in adolescence is giving you skills or psychological traits or facets of mental health that you're going to carry over when you're 19 or 20. It doesn't stop automatically when you're 18. So we might think that there's a lot of reasons why what's happening in adolescence has a long-term effect. Arguably, nobody really cares when you're 30 how popular you were when you were 15, right? And some of us might hope that's the case, right? That no one cares anymore. So I think this is an important empirical question. Does all of this wealth of research about adolescent network structure speak to anything about adult mental health? And if we take the life course perspective, this starts to give us some theorizing for why we might think it does, in fact, matter. So in the life course perspective, we're thinking about individuals in these trajectories of health and trajectories of social relationships over time that matter across different life course stages. And so sure, each life course stage might have, you know, a particular focus or a particular developmental goal, but what happens to you at an earlier age is going to affect your health or your social relationships at a subsequent age. And within the life course perspective, we're also thinking a lot about linked lives. So this idea that who we are connected to, how we are connected to other people is affecting our health. And so if we put these two ideas together, it's not just your current linked lives that affect your current health, but it's also the prior linked lives of your prior life course stages, which are going to have effects on your current health. And so we can also get some intuition for why adolescent network structure in particular might matter for adult mental health. So if adolescent networks are affecting adolescent mental health, it might be creating a kind of set point or a baseline for mental health that carries into adulthood, right? So if you are having higher sociality among your adolescent friends, that's lowering your depressive symptoms. You might be more likely to continue in that path of lower depressive symptoms into adulthood. And adolescent peer relationships are conveying many, many kind of tangible and intangible skills in this developmental stage. So they're critical for socio-emotional development. We learn things like how to manage conflict, how to maintain intimacy in social relationships. And if you are missing those developmental goals in adolescence, you might not be accruing them to the same degree later in adulthood. We also have evidence that our peer relationships are creating kind of a feedback cycle of social skills. So children and adolescents who have high social skills get more opportunities to interact from their peers, right? People want to hang out with the socially skilled, fun people, okay? Which creates even more social skills. And we kind of see this accrual of social skills and opportunities for interaction for people who are highly social skilled or interacting with their peers. The flip side of that is that for youth who are not highly social skilled, they're getting fewer opportunities for interaction. And we see a further skill deficit kind of accruing over time. We could also think of a lot of psychological or psychosocial factors that might relate to adolescent networks that could have persistent effects. So if you see yourself as belonging in a situation, if you have, a sense of higher self-esteem or social status, that might carry over to affect your mental health into adulthood. And so Christina led a paper that was really trying to answer this question. Can we observe how adolescent networks, particularly sociality and popularity as these building blocks of structure, predict trajectories of mental health into adulthood? Moreover, we know that social networks tend to differ by gender. So adolescent peer network structure tends to differ by gender. We know that depressive symptom rates and other factors about mental health tend to differ by gender. So if we see an association between peer networks and mental health over time, we expect this might also differ by gender. We are lucky to have this work published now for a couple years, so I'm not going to go in deep on kind of the methods and data. I hope you all look it up for yourselves and tell your friends and assign it in your classes, etc. But I do want to give you an overview of what we find because it provides this springboard for the work in progress that I'm going to talk about today. So we're using the AdHealth data so we can look at trajectories from ages 12 to 32 in this particular study. And we find that sociality is related to persistently lower depressive symptoms. So the youth who are naming more people as their friend in adolescence have fewer depressive symptoms in adolescence, and that difference does not go away. It is maintained into their early 30s. Okay? And we see a pretty consistent pattern here for young men and young women, right? So we also see some of the features we would expect about mental health trajectories. So women tend to have much higher depressive symptoms on average. We see kind of this curvilinear effect of higher depressive symptoms in adolescence that really becomes fewer depressive symptoms in early adulthood before ticking up a little bit into individuals' 30s. But the highlight here is kind of the effect of sociality on lower depressive symptoms and trajectories of lower depressive symptoms is maintained well into individuals' 30s. Popularity was a little bit different. So here, popularity was not significant for the mental health trajectories for young men. And for women, it was a bit more of a complicated story. So young women who are highly popular in adolescence, so they're being named more by their peers in adolescence, were actually more likely to be depressive. So they had higher depressive symptoms in adolescence. But this then translated into a steeper trajectory, so lower depressive symptoms by the time they were in their early 20s. And then it kind of converged into their 30s. So we could think of this as an initial risk to mental health that became a benefit to mental health in your early 20s, and then kind of fizzled out a little bit, kind of went away and to converge in their early 30s with compared to their counterparts that were less popular, right? So a bit of an interesting story here with popularity. Now, we were quite surprised, quite pleased, I think, to find that your position among your peers, just your popularity and sociality in adolescence, is related to mental health all of these years later, right? Even in your 30s. And so the logical next question, I think, is what about everything that happens in between? Right? What about all of these milestones that we think about in your late teens, in your early 20s, in your early 30s Why would your friends and your position among your friends in your teens still matter despite all of these intervening life events? So in the life course perspective, we know that there are many major life events that are happening in this age, many transitions to adulthood, things like going to college, completing college, maybe getting married, or having kind of more sustainable, serious, intimate, romantic relationships, etc. So there are kind of key adult roles at these life course stages that might be intervening in this process between adolescent networks and adult mental health. So we're thinking about trying to unpack this black box a little bit about why networks are relating to adult mental health, and really decided to focus on adult roles. So kind of these core transition to adulthood types of roles, like getting married, completing college, being employed, being residentially independent. And we have quite a bit of research that these kinds of status attainment roles really matter for our mental health, right? So the impact of marriage or having a college degree is really important for mental health in adulthood. So being able to attain and maintain these statuses has a major effect on adult mental health. We have less research about how adolescent popularity and sociality might predict these adult roles. So most of this research is not thinking necessarily about network structure, right? But we have some indication, some theorizing, some prior work that's showing that really it is a story of socio-emotional development, that if you can learn to maintain friendships in adolescence, that predicts a much higher likelihood of having satisfactory, serious, long-term romantic relationships in adulthood. Or there's some other work that's more focused on social status and social skills. So some work from Ying Shi and Jim Moody that shows that popularity, this specific measure of how many times you are named in your friendship network, actually relates to your income in adulthood, net of all of the other intervening factors you would expect, right? So net of a lot of socioeconomic or personality covariates, your popularity is still predicting your income. And other work using long-term longitudinal survey data out of Sweden that finds that peer marginalization at younger ages is related to unemployment, to receiving social assistance, and to lower educational attainment. So we've got some inkling that networks matter for attaining these adult roles, but it's not always clear what the expectations might be for popularity or sociality specifically. So overall, we can think of these adult roles affecting mental health. We see this trace effect of networks on adult mental health. And we know to some extent networks might be affecting these adult roles. So can we put these pieces of the puzzle together? So our research question is asking, are there pathways between adolescent networks, specifically popularity and sociality, and adult mental health mediated by adult status attainment roles? So does your popularity and sociality in adolescence among adolescent peers relate to your adult depressive symptoms through the likelihood of you being married, being employed, having a college degree, being residentially independent? So this is kind of the new work in progress that we're building on today. Just like our prior work, we expect this is gendered. These are still highly gendered processes. So the way that individuals still sort into different social roles at different ages, the way that those social roles affect adult mental health is still a highly gendered process. It might not be as strict as it was 50 or 70 years ago, but we still see pretty distinct gendered effects in terms of, marriage and education really mattering for women, but employment and independence mattering more for young men, et cetera. We continue to see these differences as well in how networks relate to mental health. So in general, social relationships tend to be more impactful on women's mental health for good or for ill. And we have this prior work now that shows that indeed there are some gender differences looking at sociality and popularity related to adult mental health. So we also wanted to ask if there are these pathways between adolescent networks, adult roles, and adult mental health. Do they differ by gender? So we're again using the AdHealth data. And so this provides the opportunity to investigate these longitudinal questions. So they interview adolescents in schools in 1994, roughly, and then they've done 5 waves of follow-up. So the most recent follow-up in wave 5 was between 2016 and 2018. So we're tracking the same individuals. We know about their friendships in adolescence, and we can see their outcomes as they're aging into their early 40s. So our adolescent network information comes from that original in-school wave. It's that sociocentric network data That's really important if we want to be able to measure popularity. So we have to know not just who you name as a friend, but who else named you. We can't do that with just something like asking if retrospectively, if you were well liked, or if you had a lot of friends, or if you were isolated, or just collecting ego networks from the adolescent's perspective. That sociocentric network data lets us distinguish between sociality and popularity. Our measures from adulthood are from the most recent wave in wave 5. So here mean age is about 37 and a half. So we're talking about individuals late 30s, early 40s. The Ad Health website has all of the information you could ever want or need about Ad Health. So I'm not going to get into the nitty gritty about things like, attrition and, response rates and things like that. But if you have any questions, I'm happy to discuss in the Q&A, or their website can probably answer it much better than I can. Our outcome is depressive symptoms at wave 5. So we've got 4 items from the CESD, and we're using a summative scale. So it ranges from 0 to 12. The mean is about 2.2 depressive symptoms. So as you would expect, fairly low depressive symptoms when individuals are in their late 30s and early 40s, kind of that life course trajectory of depressive levels we would expect overall. And for adolescent networks, we're measuring popularity, or in degree in network terms, and sociality, or out degree. So in Ad Health, they could name up to 5 best male friends and 5 best female friends. So the survey design caps them at sending 10 nominations, but people might have been named by more than 10 people in turn. So popularity can range from 0 to 14. For adult roles, right now we're just looking at a binary yes/no kind of status in the current wave 5. So your college degree, whether or not you're married, whether or not you're employed, and residentially independent, so not living with your parents or roommates. We also have a binary measure for gender as male/female in Ad Health. And we're controlling for a host of kind of typical SES and relevant covariance. So we're controlling for age. We're trying to get a proxy of your SES in your childhood home by looking at the highest parental education among your parents. Also controlling for race, ethnicity. We control for school size, just in case there are differences across popularity and sociality for different size schools in Ad Health. We also control for the number of out-of-school friends. So did they nominate people who are not in their school to maybe get a sense of who's spending their social energy outside of school? And we can't, follow up to measure what the people not in the survey would have said about the respondent, but we could at least control for the fact that they were naming people who didn't get matched. Yeah, question. Yeah, they aren't necessarily symmetric. So there are certainly people who are claiming a lot more friends than are claiming them in turn, and vice versa. People who are more popular and only claim a few friends. So it tends to be on average symmetric for most people, but there certainly are kind of outliers where it isn't balanced per se. Yeah. Yes.
Yeah, I wonder how you think of the mental health as a state. Do you think that we are confounded in content or the consequence of all of the consequences of the adolescent?
Yeah. So I'm going to pause on that question. If I don't come back to it in the models, remind me, right? So we can have a measure from similar CESD measurements of depressive symptoms in wave 1. It's actually in the wave 1 in-home survey, which was conducted months to a year or two later after the in-school survey. So we don't have contemporaneous measure of CESD depressive symptoms with the networks, but we have networks subsequent depressive symptoms at the wave 1 in-home, and then depressive symptoms in wave 5. I can tell you that all of the main models I'm going to show you today do not differ whether or not we're controlling for wave 1. And I'll point out the one small difference that we do observe. Okay, so it's not included in here because I think there's an interesting conceptual distinction. It's a different research question, right? To say that your adolescent network affects your subsequent adolescent mental health, and that adolescent mental health might be what's affecting subsequent adult role attainment or adult mental health, right? It's really like a depression continuity theory and kind of that idea of a mental health set point. So I think that's interesting and valid, but it's a little bit different because it becomes this kind of like mediator rather than a contemporaneous confounding control, just because of the design of Ad Health. And luckily what we're finding is entirely robust to including it or not. So it's a good question, but it doesn't change things. Any other clarifying questions before I move on? Yeah. Sure.
Distinguish change whether the synergistic are female.
Yep. When we control for proportion same sex, it doesn't change in that sense. So we looked at kind of proportion of the sent received ego network. So of your sent ties or of the people, the alters who name you in turn, does their average gender affect the patterns we observe? So that's one way we looked at that as a control. I think again that it's likely a highly gendered process, and we could go into much more detail about the content of your adolescent networks in terms of individuals' characteristics, in terms of their health behaviors, their own mental health, and I'm happy to do that work one day. But right now we're doing the proof of concept on the adult role mediators. Is that what you were getting at? Yeah.
They're not separated out at all.
Yeah, it asks, are you working for pay? Yep. So at this point, the complexity of the pathway models, from measuring things from when people are 12 to when they're in their early 40s, we're keeping the mediators fairly simple. But it's true, there's probably a lot of complexity around those adult roles. And to the prior question around the adolescent networks as well, that right now we're just kind of starting here, and we can dig into that, or y'all can dig into that as we go. Yeah. Okay. So to tell you a bit about the method, now we're using path analysis in M+, and this really gives us kind of two sets of results, right? We can think about each pathway separately. So we can think about how popularity and sociality relate to adult roles, how those adult roles are then predicting adult depressive symptoms. But the real kind of best practice here is that we can think about the entire indirect pathway holistically. So just because popularity or sociality might predict an adult role, and that adult role might predict depressive symptoms, doesn't mean that popularity or sociality significantly predicts depressive symptoms through that adult role. So we can test that explicitly and provide kind of a stricter test of understanding these more holistic pathways, and really a stricter test of deviation here for the adult roles. We're using gender stratified models. We can compare the across the gender stratified models with the Wald-Chi-square test. We're clustering within schools to account for the fact that the networks and the adolescent measurement was clustered within the same kind of setting, using FIML to address missing data. And then we've got about 8,500 cases. So this is folks with valid network data and a valid measure of wave 5 depressive symptoms. So about 8,000 cases, which, considering we're talking about such a span of time, is pretty good. So I want to walk you through kind of the results a little bit first. So just testing, do we see this same association between adolescent popularity and sociality and depressive symptoms now that we're measuring a little bit later into adulthood? So if the prior work was mostly looking in individuals' early 30s, now we've pushed it even later into individuals' late 30s, early 40s. And in fact, we do see a similar pattern. So both sociality and popularity, net of covariates, are predicting depressive symptoms years later, decades later. How popular you were, how many people were naming you as a friend, how many people you were naming is predicting your depressive levels in your late 30s and early 40s. Yeah.
Linear model.
In the path analysis.
Yeah. Okay.
Yeah. Yep. We also see that popularity and sociality are predicting adult roles, right? But there's a little bit of a difference here between the two measures. So popularity is predicting an increased likelihood of being married, having a college degree, being employed, and residentially independent. So all 4 adult roles that we're measuring. For sociality, it's only significantly predicting marriage and college degree. So we're already starting to see a bit of a difference between this concept of how other people see you versus how you see yourself related to adult roles. Now, these direct effects of popularity and sociality on depressive symptoms, once we consider adult roles, change a little bit. So as we would expect from the literature, adult roles are related to lower depressive symptoms. So being married, being employed, that generally predicts lower depressive levels than people who are not married or are not employed. And when we account for adult roles, the direct effect of popularity becomes non-significant. So we see an attenuation of this direct effect of popularity. So this is giving us kind of our first indication that there might be some way that these adult roles are mediating associations between popularity and depressive symptoms. However, the direct effect of sociality is maintained. So even after we're considering all of these covariates, after we're considering the adult roles, right, whether or not you're married, whether or not you're employed, even taking that into account in the model and netting that out, we're still seeing this effect of adolescent sociality on depressive symptoms. So to give you kind of the official path model here, I'm going to try and highlight some of the components. So sociality is directly predicting lower depressive symptoms, and that persists after we include adult roles. And we see that sociality continues to predict having a college degree and being married. Popularity is predicting all 4 adult roles. So again, this is assessed holistically in the path analysis model, but I'm just trying to break down the components to make it a little more digestible for you. And all 4 adult roles are predicting depressive levels. So in the ways that we would expect, this adult status attainment is beneficial for your mental health. When we consider the overall indirect pathways of popularity or sociality predicting depressive symptoms through these roles, we see the same patterns of significance. So for sociality, we see this significant direct effect, and that indeed the indirect pathway from sociality to depressive symptoms through marriage and college degree is significant overall. So it's not just the little pieces that are significant, but when we kind of assess it all together, it's also significant for the entire indirect path. Same for popularity. So sorry, we're getting a little technicolor here. I've also taken the coefficients out to try and make it much more legible. So I'm sure that's a sin in the SEM world, but hopefully it makes it a little more readable, right? So popularity is predicting depressive symptoms through all 4 adult roles, and that's significant for the overall and indirect pathways. When we look at our gender stratified model, so this is modeling separately for people who are identifying as male or female, we see that the direct effect of sociality is only significant for women, or in the model, the female model. Sociality predicts college degree in the model for men and in the model for women, but it only predicts marriage in the model for men. So again, seeing a bit of a gender difference there, and this effect of how you see yourself in your peer environment, predicting roles in depressive symptoms in adulthood. For popularity, all of the 4 pathways to adult roles persist. The same effects from adult roles to depressive symptoms are the same in both genders, right? So we don't see gender differences for popularity or how the roles are relating to depressive symptoms. Now, when we test for significant gender differences with the Wald-Chi-square test, we're only seeing differences in how the roles are relating to depressive symptoms overall. So for marriage and a college degree, they have a much stronger effect on depressive symptoms, a much more beneficial effect to mental health for women. Employment has a much stronger effect, a much greater benefit to mental health for men. So we see a bit of this kind of traditional gender roles, probably more traditional than we would have expected, really, the effects of gender roles, where what's really mattering for men's mental health is whether or not you're employed in this kind of breadwinner role, compared to, for women, it's social relationships through marriage and it's educational attainment with college degree, having stronger effects. So again, that's what significantly differs. That's not to say it doesn't matter for the other gender, just that it's stronger in those directions. When we look at the indirect pathways based on gender, so again, this is the overall pathway from sociality and popularity to depressive symptoms through the roles. We see for women that sociality, again, has that direct effect, but it only operates through college degree. So sociality predicts depressive symptoms through whether or not you're getting a college degree. For men, the pathways here, sociality relates to depressive symptoms through marriage, right? And through popularity relates to depressive symptoms through all 4 roles. For women, residential independence is not significant in the overall pathway. So that's in blue there to try and indicate that that was significant only in the male model. So popularity relates to depressive symptoms for men and women through marriage, employment, and college degree, but only through residential independence for men. So seeing a bit of a gender difference here in kind of these overall pathways that maps pretty well onto what we observe if we were just looking at the different component parts as well. Overall, I think this research answers our first research question that indeed these adult roles do mediate the associations, certainly between popularity and adult depressive symptoms, and to a lesser extent, sociality, because we still see that direct effect of sociality that even after including the mediators and the covariates is not fully attenuated. We also have strong evidence here for gendered pathways. So there's little gender difference in how popularity and sociality predict the adult roles, and there's little gender difference in how those roles predict depressive levels, but we do see some key differences in the overall pathways. So for women, sociality directly predicts depressive levels and it operates through college degree. For popularity, for women, it's only predicting depressive levels through marriage, employment, and college degree. For men, sociality is operating through marriage. We don't observe that direct effect on depressive symptoms, but popularity is operating through all 4 adult roles. And again, the key significant gender differences here is the extent to which certain roles matter by gender. So marriage and education having a greater impact for women, employment having a greater impact for men. In terms of next steps, I think overall this indicates that we need to be thinking about adolescent networks having long-term effects for more than just mental health. Certainly more aspects of mental distress than just depressive symptoms. We know that depressive symptoms in particular tend to be a highly gendered behavior. So are there other aspects of mental health, mental distress, or even physical health and well-being that we could be considering here? I also think as a networks person that examining popularity and sociality is just the start. These are really these fundamental building blocks of sociocentric networks. And we have decades of research into adolescent network structure that shows that there are many more reasons that your network matters, many more aspects of network structure that matter for adolescent mental health. And we can kind of take the same tactic here of seeing how they matter long-term across different stages of the life course into young adulthood and adulthood. I think that this research on adult roles is starting to unpack the black box a little bit, right? Thinking about kind of these key status attainment life course roles, but there are still a lot of open questions about the mechanisms through which this might be working. So is it a story of social skills, right? If you are highly popular, you're getting more opportunities to interact, so you are going to do better in college, you're more likely to get a degree, you're going to succeed on the marriage market, etc. So is it a question of skills? Is it more about socio-emotional development or psychological experiences that if you are someone who sees yourself belonging, you might be more likely to go into tertiary education. You might be more likely to, choose to opt into other social relationships. I also think that this somewhat glosses over the extent to which young adult experience might be mattering, right? So a lot of these events that are happening especially as our time of emerging adulthood and young adulthood tends to extend, there's a lot that could still be happening in this intervening period that we could examine. Overall, I think that this research speaks to the need to think about adolescent network structure affecting our pathways through life. So this isn't something that stays in adolescence and stops mattering as soon as you turn 19 or 20, but what we know about adolescent network structure in particular can relate to long-term life course mental health. And it's in ways that are highly gendered. So if we're not considering gender, I don't think we're seeing the full extent of the story here, particularly when we're thinking about social relationships, network structure, and mental health. And we've got kind of this puzzle of the long-lasting life course implications of sociality, right? Sometimes it still seems like a miracle to me that what we observe about who you name as a friend in adolescence is predicting your mental health when you're 40, right? And we can't control it away, right? So there's something interesting to explore here about what sociality can mean across the life course. So I think this calls us to consider network structure much more broadly across the life course and thinking really about kind of the structure and the web of relations that creates a position for individuals that might matter in long-term ways. And so there are many more factors that might be contributing to adolescent network experiences that we should be considering. So for example, not just gender differences, but race and gender differences, right? Or to the question about the gender of friends, most of my work examining adolescent mental health is thinking about network structure in tandem with network content. So it's not just how you're connected to people, it's who you are connected to. And the features of those individuals, their health, their mental health, their health habits, their gender, their race and ethnicity might work in tandem with that structure to have different effects. And those effects might be long-term, just like what we observe for popularity and sociality overall. I also think that there's a lot more that needs to be said about context. So the contextual situation of your network, right? It could be about network structural features. It could be about the context of your school or your neighborhood and the context of your adulthood, right? Whether it's neighborhoods, family life, but this work so far is not thinking about that contextual feature or that contextual picture. And that's something that we need to be considering. So with that, I'd like to thank the funders for this project and my co-authors again. And I look forward to any of your questions. Thank you. Yes, yes.
Yeah, just going back to the question.
Yes. Yeah, so I think the way to do it would be to do exactly what you said, right? To measure the mismatch between your out degree and your in degree, right? Or the asymmetry. I don't, however, think that it only matters to the extent that it's asymmetric, right? So I do think that there's likely, at least from prior work looking at adolescent mental health, there's likely some kind of threshold process, right? So there's a big difference between having 0 friends or having 0 out degree or in degree compared to having 1 or 2. That's different than the difference between 2 and 4, say, or 4 and 6, right? So I think that we observe kind of the exacerbated effects of social isolation in that way, or even relative social isolation. And I think that the extent to which our relationships are mutual, right, particularly if we're interested in kind of psychosocial mechanisms, that matters too. So it's not just that the people where there is a huge mismatch are the only people for whom it matters, right? But I do think you're right. I think that's an interesting research question, is it the extent to which you disagree with other people's perceptions of yourself? Yeah. Yeah. Yeah.
There any like
Yeah. Yeah, great question. So we don't test that in this study specifically because we're controlling for school clusters, right? So we're kind of, if there is an effect of, say, the urbanicity or the rurality of your school on the way that your networks are relating to your subsequent mental health, we should be netting that out when we're controlling for school clusters, right? I think instead of just controlling it out, there's probably an interesting research question about that. And luckily, AdHealth was a nationally representative survey in 1994, right? And you can include weights and things to try and stratify in the back. And despite some of the attrition that happens as they go into wave 5, I said wave 4, I meant wave 1 in school. Sorry, 1994, wave 1 in school. So it is nationally representative. So we're not measuring only urban kids or only rural kids. We are controlling that out by controlling for the school clusters, but I think that's an interesting research question too. I think, we got a lot of work to do in this area to think about how it might be different. I will say from other research I do that is focused mostly on rural or semi-rural populations, we tend to see the exact same kind of peer patterns that we observe in urban settings, right? So I don't think we have a lot of consistent expectations for why peers operate differently in terms of health and mental health in rural compared to urban settings.
yeah, I like and so
Yeah.
and I mentioned like the first school kid already something. But the part that you're about with this is connected when you're able to look at what the sociology, but some people are saying I'm so and so. Like if you look at your life, like how they like they face method or like what they are people that they work with that how it's like I grew up with someone but I basically also got it.
Yeah. Yeah, so we're quite limited in our ability to look at that in AdHealth, right? So it does not track networks over time. We're getting networks at the first slice in adolescence for a small subset of schools, right? For approximately 16 schools out of the entire sample, 14 of which are very small specialized settings. So there's really only 2 schools of any size to measure. For those settings, you get a wave 2 measure of networks. So you get a little bit of longitudinal difference. They're still within high school. So we can see some changes in behavior. We could see changes in grades or course taking, for example, but we can't see, did they also get married? Did they complete college, et cetera? We also don't have any measure of whether or not they're in contact with the same people, right? So the story of this isn't necessarily that they're connected to the same people and we observe those same networks later on. And right, it's the initial networks having this long-term effect. Christina?
So our health network is based off like 9,000 kids, but the in-house school is 20,000. So there is a way if you're interested, I don't know like how much is worth it. Like Molly and I have stuff we're constructing the network
Oh, yeah.
based on the content I see, other stuff that
For a very cruel
looks like
review.
that.
Yeah.
Have the actual like I of people's friends
Yeah.
that you could then go and link to if they're in the in-home survey. So it's like
That's true.
it
Yep.
would only be possible for those who someone already has that thought, you know, through the in-home survey.
Which was also purposefully very few people in each sample and not in the saturated
Yeah.
school. So by design, yeah,
So,
exactly.
you know, so it's like they're getting little bits. So
Yeah.
we could probably do it, but yeah, I don't know.
I'm trying to match and figure that out.
Yeah.
Yeah. Yeah. Right.
I think WLF has.
Yeah.
On
Yeah.
there's some stuff that might be better. That might be a better.
Yeah. Yeah. I think, particularly for and then the longitudinal length that you get, right? You'd be able to ask a lot more health questions if you're not just tracking people to their early 40s. Yeah. I think that speaks to all of that network content that we could be measuring, right? So this isn't even talking about, is it the grade, the GPA of your friends that's affecting whether or not you're getting a college degree? Is it something about advanced course taking? Like there's so much about kind of key behaviors, both for adult roles and for mental health, that we haven't even begun to consider because we're just looking at in degree and out degree right now. Yeah. So
One more thing.
yeah, of course. So because it's a CESD, it's what would be characterized as depressive symptoms, but it is a little bit of a kind of depression anxiety mix, at least especially with the wave 1 controls. But no, it's just CESD depressive symptoms, I would say. Yeah, sure. Yeah. Yeah, so I think that's interesting, right? Something about the way that you see yourself belonging, right? So I think of sociality as being the one that is much more tightly connected to kind of these psychosocial mechanisms, right? It's not so much about hierarchy or status, but really something about how you see yourself as belonging in the peer environment, or the way that you are connecting to others has this persistent effect on depressive symptoms. I think without wanting to kind of like overread into it, though, we know, first of all, that popularity is ambivalent for women, right? It's this double-edged sword. So sometimes popularity helps, sometimes it hurts, sometimes a little bit helps and too much hurts, right? So maybe the reason why we're observing direct effects for sociality and not popularity for women is because of the risks of early popularity in adolescence and young adulthood, right? And in general, I think we have a lot of evidence across the life course, not specific to networks, that women are much more sensitive to their social relationships for their mental health in general, right? So women are extracting more social support that benefits their mental health from their social relationships, but they're also getting a lot more stress, right? And they're doing a lot more kind of kin keeping and things like that, that are affecting mental health. So I wonder if it's just that we kind of observe the needle moving more for women, but we can't discount that there's certainly something about kind of these psychosocial mechanisms. And so I think we need to unpack those mechanisms more and see, is it more of this socio-emotional process, or is it something that is more skill-based, right? But I think it's interesting. I think too, to the point of that prior question, right? That also persists even when we're controlling for wave 1 depressive symptoms. So to me, it's not a depression continuity story, because it's not just your adolescent networks make you depressed or happy in adolescence, and that's what you stick with for the rest of the time. Because we see the effects that I showed you today, with the exception of residential independence, right? That's the one that like kind of flickers on and off depending on some of the controls, right? So there might be something interesting about residential independence and the way that your prior mental health affects your residential independence, but certainly for the direct effect, it's an interesting question, and that's kind of what I'm thinking about it. That it's probably mechanisms, but it's probably also about women's responsiveness to their networks in general, especially with mental health outcomes, right? And that sociality is much more unambiguously beneficial than popularity for women. I'm going to go in the order I saw the hand. Yeah. Yeah. Yep. Yep.
Like, how are you thinking about like not
So I'm going to just click back to the path diagram here just to have that up while I talk. But so in the path analysis, we are controlling for the covariance of the residuals, right? The way that it's being modeled is accounting for the fact that these are not four separate things, right? That they are related to both the predictors and the outcome in ways where their errors covary with each other, right? So we're accounting for that in a model in a way that it shouldn't be messing up what we observe, essentially, right? Now, I think you introduced, again, another interesting research question of what about moderation, right? So this is simply a story of mediation so far, but we know that there's definitely moderation in the way that those roles relate to each other, right? And there certainly could be other features of moderation that might impact the effect of sociality and popularity on the roles or even overall pathways. Up here.
I want to go back to, I think, what Boyan was thinking during the talk.
Yeah.
This idea that sociology and popularity are exogenous. Like, how do I think about that with these data? Do I need to be worried that there are personality attributes or other things going on that lead to be popular and then have long-term benefits, or is that possible?
So I think there's kind of two components to this, right? So I think that there's always stuff that is going on before we measure them that probably matters, right? There's a whole host of stuff before wave one that's happening, right? They weren't kind of newly created for the wave one ad health in-home survey, that day they took the survey in school, right? So there's all sorts of factors that are going on that are affecting likely their mental health, right? Their home life, which could be affecting adult roles in many ways, right? And popularity and sociality. So that's not something that we're speaking to. The extent to which other contextual factors are mattering for the initial state of sociality or popularity, right? In general, in networks research, I don't think we've controlled for personality in this particular model, right? But when we control for kind of the classic personality measures that we have available, it doesn't tend to negate or attenuate any of the effects of sociality and popularity on mental health outcomes, because we tend to see something specific to structure. So if we were measuring something like perceived popularity or perceived likability, right, or even just only ever measuring out degree, then there tends to be a lot more effect of both prior mental health and personality affecting your perceptions of your social standing, but tends to not be the case with mental health outcomes when we're talking about these structural measures. I think the other component for that is, to me, if I play it out theoretically, right, that there is something about popularity and sociality that's endogenous to the kind of person you are. If I'm expecting that to impact depressive symptoms all these waves later, I would control for early depressive symptoms, right? So that's exactly why we test that. So if there's something about your mental health that's making you unpopular or making you highly social, right, then when we control for the wave one depressive symptoms, this should drop out, and it doesn't. So I think that's some indication that what we're observing is not entirely endogenous to a mental health process, and we're just kind of picking up the trace of it with network structure. Yeah.
Thanks so much. I'm great, like you are, I think, by the second. It's kind of persistent direct type and socially your type. And I'm interested in expected state to maybe tease out what's around there. I was thinking you kind of measure whether persistence of the effect of sociality over time, or maybe it's the sociality itself, like people
yes.
You don't have to fade away. But maybe it's possible for knowing whether I is durable to be in ad health, this eye that's going to kind of build these networks. So essentially, if people do these ties, are they part of the equal networks that's very dense?
Right.
To be predictive of great longevity of the tie.
Right.
Would be a way of getting to the end.
Right. So I think about it kind of off the top of my head, or to the extent I've thought about it so far, I suppose, in two ways, right? So what are the other kind of social network reinforcing mechanisms that might predict what we'd expect to be tie longevity, right? So density, certainly, of the ego network, or even kind of, transitivity, if it's balanced, right? Things like that. There's so many network measures that we could throw out this to try and see what predicts stability. And actually, I have some, forthcoming work that is with the Prosper data that is looking at types of stability and finds that, in fact, it is having those mutual ties that is one of the major factors reinforcing stability, right? So I think we could do that. I also think that, what other proxies are there for kind of being a social person in the subsequent waves of ad health, right? So are there other things? I know in one wave, I think wave 3, I'm not exactly sure if it's wave 3 or wave 4, but they ask like, how many friends do you have? Which we know is not the best measure, right? Especially, I mean, I've seen surveys where they ask that of adolescents and they're like, countless, right? Like everyone thinks they have different numbers of friends, maybe in ways that are very endogenous, right? When they're not naming a specific person. So, that it kind of hurts my network science soul to say that the name generator that is measuring and matched kind of within a school setting is the same as how many friends you say you have when you're 30, right? But maybe that could be a proxy for it. Honestly, I'm surprised it's not attenuated by marriage, right? Because I think there's this idea, if you're a friendly person, right, what it means to be a friendly and social person when you're 15 is to be, naming all of these friends and to have friends. What it means to be a friendly and social person when you're 25 and 30 is to be married, right? And that certainly is an important indirect pathway for men here to mental health, but it doesn't attenuate the effect for women. So already I think that's a little bit kind of getting at this idea of something that we might expect to explain away this direct effect, and it doesn't. But yeah, I'm definitely interested in thinking more about how different types of network structure might matter in ways that we could start to tease apart some of the conceptual mechanisms, even if we can't directly measure their networks when they're 30. Yes. Yep. Yeah. I'll be honest, I'm going to punt this one to my co-author because I know we've talked about it and I forget the reasons why. Could you speak to that, Christina?
There's a couple of research that I think the main one is really strange that some of the folks in the are, like 29, for example, it's like not being married by 29 is diagnosed like a failure. Like that's pretty normal. And
Even
so wanted to go it was really simply just the age range. So wanting to kind of think about that stage of life course, the benefit of bad health is that they sort of represent stages of the life course. So by mid-adulthood, having not accomplished accomplishing them in age work would almost be, something different, right? Especially for marriage and especially for my cousin, kind of like computers and a lot of work with ad health and depending on what that means for the different countries with ad health. But really the main thing is that we wanted to consider that if you didn't accomplish it, it was almost like a stigmatizing by the state. And so to ensure that you're not employed by age 40.
That's a big difference than being unemployed when you're 25.
Yeah. Going to office programs, etc. And so want to make sure that it's really clear that it did not happen. There's indication of
and when it's not just conceptual, but empirically, when you look at the rates of marriage and employment and educational attainment from way 4 to 5, it really does bear out in the data as well. So I think too, the other thing to keep in mind with ad health are the period effects of the recession, right? So that we observe around education and marriage. So we're getting further away from that with wave 5. So, but I think to your point that having the mediators precede the outcome is an, yeah. Have you ever? Yeah.
So we feel like the temporal order is pretty clear. We're technically measuring this.
Yeah. Thank you. Yeah. I forgot that part. Yeah. Because did you have, like, are you married, right? You're not getting married on the day that you're getting your depressive symptoms exist or measured. They existed. Yep. Within the last 2 weeks. Yeah, then it might be endogenous. That's true.
Clear, but
really, we're just waiting for wave 6. That's what we need is the wave 6 data. Yeah. Yes. But that we're an adult answers. How attractive is this child? Yeah. No, we did not. We did not. I mean, I think that's really interesting. And I think there's, the little bit of work that's been done with that variable in ad health really speaks to how that is kind of this latent factor that we really rarely talk about in sociology that probably matters for people's kind of social status and social attractiveness as a friend and their popularity. So again, I think that's a really great research question we could consider. I will say that some of the prior work, like the work by Shi and Moody that looks at this particular measure of popularity, predicting income in, I think, wave 3 for that, it's either 3 or 4, does account for attractiveness and personality and a much broader range of those figures, and what they observe is not attenuated. So that's a different study, a little bit of a different outcome. I think it's an interesting empirical question. I suppose my bias in not using that measure is the way that it somewhat kind of equates like this structural feature of the sociocentric network data with what an adult interviewer says about a teenager as being attractive. Right. So, yeah, I think that there needs to be a very thoughtful management of what it would mean to make sure that is not saying something kind of damaging and not like equating in a very awful way, right, the sociocentric network data with that measure. But it would certainly be interesting. Yeah. I feel like you've given me all now a dozen new projects that we need to work on. So thank you. Yeah. Yeah. Yep. Yeah. Yep. Yep. Absolutely. Yeah, so I think you're exactly right that there is a lot of kind of cultural variation, right, in expectations or stigmatization against independence or non-independence. I also think that a lot of it is driven by just kind of by the wording of the question and the way that they're asking, like, are you living independent and independent in your own home away from parents and roommates? Like, I can see a lot of scenarios where people aren't necessarily living with their parents, but it's not really a binary measure, and we're forcing it to be binary here, right? And in fact, I think when we kind of do some of the measurement differently with the binary, right, like modeling the logits instead of the linear probability model, that is one of the changes that we see. So there's something specific to the measurement of that variable, that it's not a binary process. And there's many more there's a lot of nuance and variation, many more shades of gray around what is residential independence in terms of what that looks like practically and how you answer that question, and what it means in terms of people's culture or race and ethnicity or gender, right? So as we kind of see, residential independence is this factor that connects popularity to depressive symptoms for men and becomes non-significant for women. And we could certainly tell a story that being residentially dependent is a lot less stigmatizing for women, right? And we might expect more social control from parents wanting their young adult daughters to live with them, or in this case, well into adulthood, but 40s. Right. So I do think those factors matter, and that's something that needs to be teased apart a little bit more, especially given the prior work that talks about sequencing of residential independence, right? So it's not just about being residentially independent, it's were you ever, and then did you move back home? And then, right, so there's a lot of complication there that needs to be dug into. Yeah. Yeah. Sure. Yes, current status. Correct. Yes. Yep, absolutely. So we're measuring your current status, predicting your current depressive symptoms. Right now, we don't have the granularity to be able to look at the sequencing. Yeah, to know if it's married, unmarried, remarried, right? Employment. Yeah, right. It's not in the model is what I mean to say. So we have that data, and again, it would be another research question. I feel like I'm a broken record saying that, but yeah. 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 Right. Exactly. Well, I think arguably it is a stigma. It's still a stigma to be unemployed. It's a different stigma from being never employed, right? So certainly what you're saying that, if you're employed for 10 years and then you choose to go back to school, that might not be stigmatizing, but arguably having a job for 10 years and then losing it right, could also be very detrimental for your mental health in a lot of ways. And we have a lot of research that shows, in fact, that is the case for employment, right? So I think what we focused on is the importance of having kind of that measure associated with current depressive symptoms without as the first step, rather than focusing on have you ever attained it, have you attained it and lost it, because those, we would expect those to have conceptually different impacts, right? So, and in fact, that's exactly what like I was just speaking to, that's what the residential independence work by Caputo shows, right? That it's not just, are you residentially independent or not? It's like, were you ever, and then you lost it. And that's what really has the mental health effect, right? Much more than people who never moved out of their parents' home. So I think it's an interesting question. I think it's a slightly different question and doesn't kind of negate what we do find about current status. But you're exactly right. It's what do you have now, not what did you ever have? Yeah. Yeah, I saw a hand back there. Yeah. Yeah, I think it's different. I think it's a different research question. So we have quite a bit of research that shows that, you know, relationship quality matters independent of relationship structure in adolescence. And so it's a question of what matters across the life course, right? And certainly I think that gets to the question of that who is connected, not just how are you connected. So there's a difference between, you know, arguably there's a difference between 3 shallow friendships and 1 really good friendship, right? And that's not something we're assessing with this. So I do think that, you know, when we're talking about structure, that has some dimension of quality, right? And some dimension of you have to reach a certain threshold of acquaintance to be one of those 5 people that gets mentioned, right, on that survey. But certainly there's much more nuance about quality that we're not capturing here. Others, yeah.
One more question. When you're thinking about those things like one of the times I do I would keep your eyes on.
Yeah.
About
Yep. Yeah, so Ad Health has measures of via BMI, and we could include that. And there's, yeah, there's some data out there. Most of it, I would say, is focused on kind of like homophily, BMI homophily, right? Rather than, you know, like influence selection type stuff. Yeah, so just like we could look at kind of attractiveness or other, you know, factors about personality, we could certainly look at how that there's all sorts of precursors that are probably affecting your popularity and sociality that we're not measuring, right? Even some of the new work that Christina and I are doing are looking at adverse childhood experiences, the maltreatment predicting your networks, right? So there is a whole host of kind of contextual conditions, physical health or health behaviors or social, you know, kind of perceptions that might be related to initial sociality and popularity that could be precursors to this, but I don't think would negate what we're also observing here. Yeah. Yeah. And there's so few unhealthy kids in adult health. Yeah. Which is, it's great. Adolescents tend to be healthy. Wonderful. Yeah. Yes. I do not, you know?
Yeah, it does.
Yeah.
We're saying that in our health, and others, so like health is definitely.
Have we tested wave 1 depressive symptoms specifically? I know I've looked at it before with wave 2, right? Yeah. For the sorghums, yeah. Yeah. Of subsequent, but okay, but not necessarily. So we've tested subsequent depression, but not 1 to 5 independently. Yeah. Yes, yeah, that's what I'm saying. So we've done 1 to 2 and 4 to 5, but yeah, I mean, once they're dropping out, they're not getting picked back up, but I don't know that there's an independent association with your mental health at the baseline to wave 5 other than the subsequent attrition through waves.
I think